Thank you. So we'll start the last session of the day. We're going to have two further sessions. The first one is going to be a genomics workshop, which is going to be an interactive teamwork from the genomics team. Over to you guys. If you're doing presentation, then you can use this.
Oh, thank you.
Should we briefly introduce ourselves?
Yeah.
So we thought we'd do it as an interactive. So we've got 2 or 3 brief slides. We thought we'd do it as an we were asked to do a workshop, so we've left the slides brief, and we're hoping for some interaction, if that's okay. And we broadened it across. So I'm Alistair Parker. I'm a tertiary level neurologist.
I'm Beena Mukhtiar. I'm a consultant pediatrician in Norwich and secondary level neurology consultant.
I'm Nicole Bateman. I am parent representative on the Ethics and Law Committee of this college and a mum of children with epilepsy.
I'm Amy McTague. I'm a consultant paediatric neurologist at Gosh and also a researcher in epilepsy genetics.
So Nicole's going to kick off from the family's perspective, I think.
Yeah. Excellent, thank you. So Dr. Parker decided to say that we should test everyone in the room with a question to start with. So this is, experts by experience, there we go, representative. And if you go to Menti, it's actually on Emma's laptop at the back, and the code is there. There is a question that I want you to answer, please. And I'm not going to say it out here yet. And I don't want any Googling either. Okay, so have a little look. Have people got it on Menti? Oh, there we go. Oh, it's coming. And Emma's going to tell us at the end what the results are. So, as I said, I'm a parent of children with epilepsy, and I'm on the Ethics and Law Committee of this college. So Emma has asked me to come along today and share what some of the parents' experiences are of the genetic testing process with you. And we're going to go through some things like what went well, even better if, and things to move forward. What went well and even better if for me, I'm education background, a teacher of 11 years. So yeah, it fitted really nicely in that. So what parents really liked is that it was solution focused, so being offered the chance, especially for those that had kids with uncontrolled epilepsy, having that other solution, looking at what the causes could be was really, really useful. So they absolutely loved that. To be actually offered the testing as well was really positive. And there was a really good explanation generally across the board about the process, about the trio, about the implications of what may be found and things like that. So that was really positive in a lot of the parents' explanations and experiences. Even better if the things were explained in kind of plain English for us as parents. Having letters that had things like isodicentric Y chromosome, mosaicism, all of those big words, often parents, I know myself, my child had a couple of seizures yesterday and the day before. So I live on kind of that high alert. I am always on high alert. And so therefore getting a letter, for example, with information like this and then Googling because, you try and work out what is this and how is that going to impact your child, then can cause even more anxiety in that state. So kind of plain English examples, also getting results via in-person, like ideally, but even just a telephone call would be amazing rather than a letter. I know that a lot of places do that and don't do it by letter, but some have. So that could be something that would be better improved. And also like timely and accurate information through shared care. So a lot of people are under a couple of trusts, and so therefore sometimes things being told by one trust and then something different being told by the other sometimes can lead to a bit of confusion on the parents, in the parents' head. And then, so moving forward, I suppose things to think about is really being mindful of that parent care estate. As they come into your office, into things like that, thinking about how they are actually in themselves. We've had a load of talk about the mental health of parent carers as well as young people. And so I think it's so important, and it's great and really encouraging to see a lot of that is on the agenda for like that support, because it is, you know, living with children with epilepsy can be really, really, you know, anxiety inducing for a lot of parents. Also that kind of parent focused resources that again can be explained in layman's terms and things like that, and that emotional support services I think would be really, really great. And yeah, and also genetic testing, getting those results can take a long time. So thinking about actually keeping in touch, whether that's something that is easy by, you know, by a receptionist or, you know, things like that. Just saying, oh, actually, yeah, it's actually going to take a bit longer, so that then parents know when their results are going to kind of come and that things haven't been lost, and things like that. So, so yeah, I think overall it's great, and we, you know, as a group of parents that have shared, really, really love the fact that we have the opportunity, because of future developments and things like that, and have access to the genetic testing, but just sharing in-person results, and also some plain English for us to for us to understand in that way. So yeah, thank you very much, and I am going to pass you to Dina, I think. Oh, sorry.
Thank you very much. What was the answer for the?
Oh yeah, sorry. And the word, yeah, isodicentric Y chromosome. How many? So Emma, did you get results?
Tell us. You can tell us what it was.
Oh, sorry. Okay, so so 5% said yes, or 5 people. 5 people said yes. 57 said no, they don't know what isodicentric Y chromosome is. 14 maybe, and 17 would ask an expert. So there we go. So now I don't feel silly not knowing what it was. I'm like, oh, phew. So, you know, that again just highlights that plain English would be absolutely amazing for everyone.
Thank you. Lovely. Really nice intro there. Just a couple of quick scene setting slides from a kind of regional neurogenetics hub in Cambridge. I guess the first question to ask is this genetic testing easily accessible? I wonder what the audience, if you had any feelings about that. Richard?
Best of times and the worst of times, Dr. Parker, as Great Man once said. So we've never had such availability of genomic testing to us in the history of mankind, but it's just incredibly hard practically to go through the process and to get results back.
So for those online, Richard Brown from Cambridge, secondary paediatrician, said that there's a lot of genomic testing available, which is fantastic, but the downside is it's very hard to navigate and get it done and do tick all the different boxes you need to do. So from that point of view, I think you've answered the next question of whether it's labour light or intensive. I think, Richard, you would probably vote it's more intensive than labour light in terms of doing this testing. Jill from Hertfordshire is saying the same. This is quite and for parents can be quite discombobulating on how far they have to go through this process. Can I ask the audience, are people clear on who is doing what in terms of these testing? Who arranges the blood test? Who does the form? Who sends off the sample? I mean, is that something that people have clarity on?
The pediatricians filling a form forms and getting the consent from the family. Sometimes it takes up to hours to complete the form. So it's impossible to do that in our clinic.
So are you working at secondary or tertiary level? Secondary. So at secondary level within an epilepsy clinic, it's the words used, I think, were impossible to fit that into the template and time that you've got for that. You're perfectly able to do the form. You know which test needs to be requested, but getting truly informed consent is very challenging for that. So I think that, there's really good points. And what about the yield of this genomic testing? What do people feel about it? I mean, is it worth bothering about? Are we getting useful results from it? So I think there's, for those of you online, we're getting a general nod in the audience here that this is useful and there is a very significant yield from it. And it just setting the scene about the yield, we'll come back in the next slide. But why should we do it? Well, firstly, I wanted to mention what it was, and testing for a single gene has basically gone. Occasionally you get some single gene testing, but certainly in Cambridge they push right back from that, and it's always the whole genome, and then you're asking what is the picture in the child, what's the phenotype, what's the problem the families are complaining of, and in the light of that, which genes are of greater or lesser interest. So whether you're highly suspicious, it's only really want to know urgently, is it a change in the SCN1A gene, and the child could have a disorder which could be potentially life-threatening, such as Dravet syndrome. It's still going to need a whole genome sequencing in Cambridge, and it's going to need mum, dad, and child. So there is no way around in our centre, or there's no shortcut to this. But hey, the yield in probable genomic cases is high, up to 50%. If you get to a child that has an onset of epilepsy under 1 year, and it's not clear what the cause of it on history or neuroimaging, then we know that up to 50% of those will have a change in a gene that's causing the disease that can be identified. But we know you only get that yield if it's the whole genome and it's mum, dad, and child all sequenced. But it's not always so good, and I think this comes back to the yield question, because we know that even in classically genetic epilepsy such as Dusa syndrome, which is an early onset epilepsy where kids characteristically drop to the ground in what we all colloquially call drop attacks, the yield is down to about 16-15%. So only 1 in 8, even with the best genomic sequencing in the world, will you actually find an underlying disease-causing variant, which is very confusing for us. And then if we look for boys and girls who are maybe 10 and have been normal up until that stage and develop a genetic epilepsy in their late and early teenage years, such as juvenile myoclonic epilepsy, which we shorten to the JME acronym, the yield is incredibly low for that. So probably only 1 in 50 cases will we find the genomic cause of their genetic epilepsy. But for some of those children, we will get an answer pretty quickly. And there are clearly advantages in getting these genetic diagnoses back. And if we look at a really good example of this, would be changes in the sodium channel gene. So we've mentioned that the SCN1A gene, if you get a disease-causing variant, it's likely to cause Dravet syndrome. And we know that sodium channel blocking drugs like carbamazepine can make it worse. And conversely, drugs that work well for the genetic generalized epilepsies can work well. And there are some now that are much more targeted, such as the cannabinoids have a good evidence base, stiripentol, fenfluramine more recently. And even gene therapy, which I think is occurring in your center for SCN1A disease-causing variants. And weirdly enough, the SN2A is the opposite way around. The carbamazepine may make it better. So early onset will give you both targeted and also disease-modifying treatments. It'll also allow us to give genetic counseling. And for me, the big one is avoiding unnecessary tests, because children under 1, as an example, with genomic epilepsies end up with a lot of invasive investigations. Traditionally, spinal fluid was taken with a lumbar puncture, and we often went as far as a general anesthetic and muscle biopsy, and all these took months and years. I think William will back me up on that. You never seem to get to the end of this diagnostic journey, which is very, very hard on families. But if we can get these results back in a timely manner, we can avoid doing all those extra investigations. And then, of course, identify strategies to help the child, because we don't always have disease modification therapies. But for some of the conditions, we know that there's a high chance of drug resistance. So you might have heard of CDKL5 is an example of often a very drug-resistant epilepsy, for which we need to think of other strategies. So yes, that it's here, but there are definite benefits to it, but clearly there are notable challenges. So to talk about some of the solutions to the the challenge of getting the testing, I'm going to hand over to Bina, who is successfully doing this in a secondary level centre.
So yes, in secondary level center, it can be very difficult for everybody. Like Richard says, it's such a challenge to get these tests done in a timely manner and also as efficiently as possible. So NICE has given us really good understanding of when we should be requesting these tests. NHS England has funded it, so we've got we are so lucky to be able to get offer these tests to our families. The problem is, how do we offer it? Do we have time to do it in busy epilepsy clinics? And do we have funding? There are very few centers in the country where they have genomic nurses who help with the consenting, filling the form, and doing it all as one-step process, doing blood tests for the family, for the parents and the child together. But for most of us, like Uma and I, who do secondary level pediatrics, we don't have access to the specialist people who can do it. So we've got to do it ourselves. If not, the families and children under our care will suffer. So we tend to follow the NICE guidelines. NICE has suggested that consider whole genome sequencing for people with epilepsy of unknown cause who are aged under 2 years when epilepsy started. So if any child, even if they are 10, but if their epilepsy had started at 2 years of age, now we can offer them whole genome sequencing. If they have clinical features suggestive of specific epilepsy syndrome, for example, Dravet syndrome, so children who have had febrile seizures in the first year of life and then have had status epilepticus, and have various different seizure types by 2-3 years of age, then we know that they may have underlying conditions, gene mutations, so they can be offered. Or, so it's not and, so all these are or they have an additional learning disability, which a huge amount of our population who we see in epilepsy clinics will have, autistic spectrum disorder, a structural abnormality. So if they have some underlying congenital structural cardiac abnormality, renal abnormality, they all may fulfill these criteria. Unexplained cognitive or memory decline, and the next one is these are for children under 2 who developed epilepsy under 2, but the next one is even if they have developed epilepsy between 2 and 3 years of age, but there is no obvious cause known, then we can still offer it with MDT discussion. So what do we do in East of England, in my place? We tend to identify children and young people with epilepsy. Either they may be seen in outpatients or they may be seen acutely with active seizures. So depending on the NICE guidelines, we identify if they could be considered for whole genome sequencing. We have a discussion with pediatric neurology consultants at Edinburgh, and also have a discussion with consultant geneticist, and then decide whether it needs urgent testing or routine testing. If this needs urgent testing, we would go down the discussion with the families as inpatient and do the blood test, which becomes a bit easier. But if it needs routine testing, then we have to find time in the clinic to go through the whole consenting process, form filling process, and arranging blood tests. And that in 20-minute clinic appointment, you don't have enough time to do it. So what we tend to do is give a whole genome sequence leaflet, parent information leaflet to the family, and then arrange a video remote consultation with the family, which is about 15 to 20 minutes, and try and do it in a very slick manner. So in the remote consultation, what are the things that you would want to discuss with families? So Nicole mentioned that we want them to give all the information in face-to-face manner. If not face-to-face, it could be virtual, but they want to know everything in plain language. So what sort of information What sort of discussion should we be doing? So what is a whole genome sequence test?
Sorry?
That's right, yeah. So yeah, we would say that it is a blood test. Families have not sometimes known as to what WGS means. So it is a blood test looking at the whole genome. There are 20,000 genes that a person may have, and looking at the whole genome. But it is very important to mention that although it looks at the whole genome, it will only it is looking at it is interested in looking at changes in the genes for that particular condition. So if it is epilepsy, we are looking at the whole genome, looking at changes of gene causing epilepsy. It doesn't look at gene changes that would cause other conditions, although it's looking at the whole genome. So that's really important to mention during the initial consultation. The other things, anything else that we would mention? It would be a trio test, so mom and dad and the child will also be tested. And then what is the reason for the test? They would want to know, why are we doing this test? Any information, any suggestion?
What would you say if the parents said, will it change the treatment for my child? What would you say to them?
It might change the treatment. Most of the time it doesn't, but it might.
Yeah.
What
Yeah.
does might mean? I wonder as a parent, how do you read might? Because that's what everyone would say, but how would a parent respond to might?
Which sometimes not helpful, because it might give you hope,
Yeah.
but actually then the results might come, and then there is actually no hope of the change of treatment that's currently not working. So yeah.
I would normally say that there's a small chance that we might find something that would change treatment. But then I think you talk about all the other possible.
What do you mean by small chance?
It depends on the age of the child and the type of seizures.
So I guess the question would be whether you need to do it in 1 in 10, 1 in 20, or small or might. But they're all things to think about, aren't they? How we give that information, and it's challenging if you don't know yourself, isn't it? And you allude to the fact that different age ranges, different populations.
Yeah, we have got some data, so I'll show some data on kind of how often it's clinically useful to make a diagnosis, and I think we can be confident as clinicians we think it is quite useful, and maybe I'll try and convince you of that later. But I think it's really important to be honest with parents and say at the moment it's largely about information and understanding what this means. And I think you also have to be really honest and
I'm really sorry, they can't hear you online because you're not near the podium.
Yeah.
I think the other thing to be really honest about is uncertainty. So there's that nice list in the record of discussion where you talk about possible outcomes and always really play up the uncertainty, because quite a lot of the time we get a result back and we're kind of on the fence about whether it is actually the cause or not. And it's important that parents understand this isn't like a full blood count where you'll have something that's clearly normal or clearly abnormal. There may be quite a lot of uncertainty for some time, and that the result might change over time. That's what's also different about this kind of test.
Yes. Yeah.
I think it's equally important to state that it's more likely than not that you may not find a genetic a change. The results might come back as normal, because the expectation is, once you say we're doing a genetic test, the expectation is that you will find something.
So just for the people online, Dr. Suresh
Yeah,
Pujara.
we can repeat the question. We can repeat if you just
Oh, at the
repeat
podium,
that.
sorry.
Yeah.
Yeah. So we are talking about what are the things we would want to discuss with family, and the suggestions have been that it is important to state one is what is the reason for the test. It may help identify the condition. It may also help, if the condition is identified, it may help with the treatment, with targeting the treatment. It may help to understand if the condition is inherited or not, and it may help to identify if someone is prone to developing that condition in the future. So one is that. The second is we want to also tell them as to what the results will be. So it can show a change in the genes which cause the condition. It may not show the changes, which we should very clearly say that as well, that the test may not give us a cause. It may give us a cause, it may show some changes, but we may still not be certain, and it may need more testing of either the family members or the child, or we may need to compare the data with other people who have similar genetic change, or it may show some changes which we don't understand, so variant of uncertain significance, or it may just not show any changes. So we've got to give all this information to the family when we do that discussion. And then next, I think we should also mention, just give an idea as to when the results will be available. So currently, if we are doing it as a non-urgent test, it takes about 1 to 2 years for the results to come back. So I've had children whose results have come back after a year and a half in our region. So families need to be aware that non-urgent tests can take that long. Urgent tests can take 3 to 6 weeks.
Dr. Heyman, what's your question? We can paraphrase it here.
It's part of the consent for their data to be saved and added to the database, yeah. So is that something that families like to hear? I imagine they would, to say you're really helping us by collecting, many samples to discover new genetic, I think that would be quite powerful. Mm.
So put the record of discussion. So I tend to share this with the families on a virtual appointment. I show them the record of discussion form and go through the discussions that we've had just now about uncertainty, unexpected information, and then talk about DNA storage and data storage, and that it goes in health records as well, and then take consent for research as well. Then we do the blood test forms, and I think our lab likes to have one blood test form for each member, so 2 for the parents and 1 for child. But what we have been doing is we put all the data in that form for the child and parent and just make 2 additional copies, so there are 3 copies of the same form. And then I created a template letter to send, so there is no clinic letter that goes, but we just send this template letter suggesting what we've discussed and when the blood test will be available, the results will be available. Yeah.
Slightly tricky question.
Yeah.
So, if they say that there is someone in my family had cancer, is it possible that the genetic test might pick up a gene that might be responsible for cancer?
Yeah, so it is possible. So we would say that the whole genome sequencing, particularly for epilepsy, is looking at the gene changes that cause epilepsy in children at a young age. But it is still possible that unexpected information like cancer gene may be picked up, and that would cause additional tests, additional discussions with different family members. So I think that is, I'll put it there in the letter as well, in the letter that I sent, that there will be some some unexpected information that can also come up, and then it may need more testing.
I think that's a nice segue into the tertiary role, because I think that's from my perception, is a tertiary role, looking at these pitfalls and problems with the testing and having a system that works in your region. We recently, 2 weeks ago in Cambridge, the lab said, "Oh, we found out the dad's not the actual dad." Which they're forbidden from telling us, so that we don't have a compromise with the child. But they'd obviously changed their criteria. We were not aware of the new criteria. About 1 in 20 of WGS, the father will think he's the father, and he won't be, because that's the national statistics on it. So traditionally with this, it's not been a problem with the testing, because you would never get a result back from the lab that would disclose that, or very rare cytogenetic changes might imply that, but you wouldn't have to disclose it. So, and I think speaking with parents myself, I say, you know, we'll be looking at the epilepsy genes mainly, so this will not necessarily tell you about your own cancer risk. So if we don't tell you anything, it doesn't mean anything about your own cancer risk. You could still carry a cancer gene. It's good and bad. But of course, on the flip side is you could get a big deletion that takes out a cancer gene as well. So I guess it's a very important one to make sure if we're arranging tests that we do have up-to-date information, and for me, standard paperwork for that is definitely the way to go, and then we can update that yearly and have one person in East Anglia who, one of our geneticists, just looks and says whether there's any change to the testing, e.g. paternity, that we are unaware of. We better keep going, and if we're into tertiary, we could ask Amy, I think. Is that right?
Yeah.
Thank you, Bina.
Yeah, thank you. So, are these my slides? Or is this you? I'm happy to do this bit, that's fine. Okay.
No, I wrote this one, sorry. They're being moved around in our creative maelstrom.
So obviously this will vary a little bit depending on where you are in the country and what your local setups are, but I think we've already heard some really great examples of good practice and innovative working, and I think we are kind of almost running a bit to catch up with this kind of service that has come, and I think it is worth remembering we are really lucky to have this whole genome sequencing. When you work with international people, they are scrabbling around trying to get tests for their patients, and to have this on a universal basis in theory for our patients I think is really powerful. So it's really important that everybody who's involved in the care of the child knows that this test is being done, because it may well have implications for the whole team. It's really important for us that we make sure that our colleagues in kind of secondary care and our colleagues with interest in epilepsy and neurology have the training. I think Bina's model obviously is working really well. I think also knowing who your colleagues are in your GLH, which is your genomic laboratory hub, and all of your hospitals will be served by a particular GLH. They also have a big interest in mainstreaming genomics. That's a big kind of catchphrase. So they want everybody to understand genomics. There's some really good training tools on the Genomics HEE website that you can look to kind of learn about the terminology if you feel less comfortable consenting patients. And it's got loads of great education about how to consent and how to explain some of these complex issues. But I think working with them well to make sure that whatever system you use locally, and it will vary, and it will vary depending on what your electronic healthcare record and how that works, making sure that you've got it as smooth and as low effort and as low stress as possible. So obviously the other thing we've talked about is the kind of timeliness of genetic testing, and the fact that some children can end up waiting quite a long time for a result, and maybe that could have impacted on their care. So it's thinking about this early and thinking about genomic testing early, so that if there are these kind of long delays that you kind of are at least in the queue. And for us, we would tend to start to think about this as one of the initial investigations in most neurological presentations, and certainly in epilepsy, depending on the type of epilepsy. But I think if you're a secondary paediatrician and you're unsure, then I would always, reach out to your tertiary neurologist who covers your area and ask them if they would fit within the criteria if you're not sure. And I think also, even if your results come back negative, and there isn't really any such thing as a negative genetic result really, unless you're doing single gene testing. So this is essentially, they've not found anything on the panel of genes that gets above their criteria at the moment. But who knows where that will be. So it's important to kind of keep an open mind with these patients. And if you have a real spidey sense that there's something going on here, then go back to your clinical genetics colleagues, ask your clinical scientists, work with them if you can, and say, is there anything else? Did the child have the right panels applied? So essentially we tend to choose the R59 panel for patients with epilepsy. But it may be that your child develops some new features, so starts to have microcephaly, develops some multi-system features, and any new features would now mean that they would be eligible to have additional panels added to their analysis. They're a little bit reluctant to do it because they're also overwhelmed with all the analysis, but that's a kind of strong indication, if you can say, the phenotype has changed and now we need to look, because it may be that the right genes haven't been interrogated. So I'm just going to talk briefly about some research we've been doing at Great Ormond Street, trying to generate, and internationally, trying to generate some evidence about some of the things that Alistair talked about, which is kind of, is it helpful to have fast results back for babies with epilepsy? So we've been looking at babies under 12 months of age with epilepsy, and we've essentially taken all comers with recent seizure onset, and we've only excluded patients where they've got already a known genetic cause, or they've got an acquired birth injury or an acquired cause. And what we're trying to do is we're trying to look at this prospectively, because there are loads of retrospective cohort studies where they've sequenced 600 babies. But what we don't know is what's the impact of firstly getting the genetic result, but also getting it quickly. Does it change outcomes for patients? So we're taking these babies, we're phenotyping them extensively, we're doing developmental tests, because we know from our own experience, and you'll know this from your experience, that many of these babies are quite vulnerable developmentally. And we want to also know that if we pick up these things earlier, can it make a difference for these kids? So we're doing this prospectively across 4 centres internationally and at GOSH. We published this recently, and essentially in the first 100 babies from our international study, doing rapid whole genome sequencing and getting the result back in 21 days as a median, we've found that our yield is about 43%. And remember, this includes babies on the ward, a couple of babies in PICU, but also many babies come into our day case unit with infantile spasms or with a kind of short 4-week history of focal seizures or other seizures. So a quite different population to what's been published before in terms of rapid testing. And what we showed overall was that it's still very heterogeneous in terms of what genes you pick up, but the standard of care testing, and that varied across the 4 different hospitals, missed the diagnosis in 15 cases where we found it with whole genome sequencing. So that might be that they were doing a very restricted panel, or they were doing other kinds of tests. This was the workflow here you can see on the left-hand side of the slide, and essentially we very quickly recruited babies when they came to the site, and as long as you can get the blood to the lab, the sequencing is actually very easy. It's the analysis that takes a long time. So this doesn't actually really count as rapid sequencing anymore. There are some studies in America where they're sequencing genomes in 4 hours, but the problem is the analysis. And as you can see here on the right, it's still genetically very heterogeneous. There isn't one gene that causes epilepsy for these babies, there's very many. So this is the real key. So it's easy to do the sequencing, it's quite easy to do it quickly, but actually the hard bit is what comes next. So is this useful, and how do you give the result back? So what we found overall was that the majority of results had some kind of clinical utility, which is the fancy way of saying it was useful for the clinicians. So in about over half of them, it influenced treatment. So that might be, as Alistair mentioned, using a sodium channel blocker, not using a sodium channel blocker. Often we put babies with epilepsy who present in the first year of life, we often put them empirically on sodium channel blockers because we suspect they might have one of the gain of function channelopathies. And the patients where we didn't find that, we could then take them off that and move on to other treatments. There were also some positives of a negative genome sequencing that can enable you to move on to other kind of strategies of investigation. But I think what's most important for many of these families, and I'd be interested in your perspective in this, is that it really does help us inform the prognosis. So it helps us understand what is the journey going to be for this child. And we're able to say to parents and to families, we think this is the cause, and in many ways that can be helpful. It is also shifting our paradigm, and that can also be difficult. So we're trying to do some research into looking at what that experience is like. So we've got some further plans on a research basis, and essentially we're going to look more deeply because we still have half of the babies who aren't getting a diagnosis, and we're going to use lots of fancy new kind of genetic techniques to try and get that 50% up, because we suspect that if we do some of this, we'll be able to find more things. So these will include looking outside the genes into the kind of protein sequencing, so the proteome, looking at kind of regulation of gene expression across the genome, and looking at various other things. And I think we also want to look at what are the incidental findings, we call them, or the secondary findings. We mentioned some of these in the consenting. So in our GOSH cohort, we've had we've had 2 in the first 50 patients that we've sequenced. And these have been findings where we've found something in the child and it's been inherited from a parent and it's had implications for a parent. So when you're doing this broader testing, which we're doing, which is not panel-based, there is more of a risk that you'll find something additional, but the yield is increased. Okay, so
we have time for one question, either online or in the room. But lovely overview, Amy. It's the best of times and the worst of times, in Dr. Brown's quote. Any questions or comments? Yeah, please.
So WGS requests are happening more, but I was taught to do CGH array as well to look for copy number variants. We're still doing that. There's the analysis with whole genome change, so we don't need to send a more basic.
Not for about 12 months, I think, is the answer to that. So we're almost there, but not quite. And when we did our publication from Cambridge, we found in 1 in 20 cases, the diagnosis was on looking for big chunks of the human genome using CGH arrays. So that should be done simultaneously when you sent it off. When we did our next generation study in Cambridge, we did that within 5 working days. And if we got the diagnosis, then we pulled the rest of the journey. So it's quite a good system because arrays are pretty quick. But it's conversely, in 2 of the cases, they found that we did WGS, and when we got the WGS result, we realized it would have been picked up on array and no one had done it. So we thought we had, but no one had actually double checked it and got to the lab.
So if you want some kind of other evidence, there's a really good meta-analysis of genetic testing in epilepsy. It was published a few months ago from the Boston group, and they've shown that if you look at all patients with epilepsy, the kind of yield of CGH array is probably one of the lowest of all genetic tests. But as Alistair says, until the WS is fully validated, so you probably will get results back that have got CMVs in, but they will still go back to the copy number lab, the cytogenetics lab, and they'll confirm them often. But I think very soon it will change and it'll be validated. It still won't pick up the short read sequencing, which is the standard whole genome sequencing, still won't pick up what we call structural variants in the chromosome, and that's probably the next big step, and that's going to need what's called long read sequencing, but that's all on research basis at the moment.
Can I finish on one line, just for thinking about the more global picture around epilepsy and services at primary, secondary and tertiary level. This is here, it isn't going away. And for those of you both at secondary and tertiary, get that sorting hat out. Work out what's Hufflepuff and what's Gryffindor. So what do you do at tertiary, what do you do at secondary? Use some economy of scale that Bina done beautifully there with some simple leaflets that work well. I always think that you need to write a leaflet for parents and then you need to make it more simple for professionals. Normally parents have very good understanding, so we can simplify things. And I think for the paediatricians in the audience who will be doing some of the consenting, you need it in your job plans, which means you need to configure your clinics for the next year and think, well, if I'm doing this about 10 times a year, and it's probably 3 hours of work per family to truly explain these things in terminology that we've heard, avoid using might possibly, then it's about 3 hours. And that's something, certainly with my team, I've encouraged people to say there are going to be clinic slots delegated to this over the time goes, because there are savings down the line, of course, because this, once you get the result, it greatly reduces a lot of other stuff you do. Suresh needs us off stage. Thank you, team.